In this other example, actually, is one of the first publications on health disparities in the US. The authors, the investigators examined whether there was a difference in the use of reperfusion therapy among patients that were eligible to receive it based on their clinical picture. And what they did, they looked at a Medicare database. Medicare is a public health insurance for people over the age of 65 and people with certain disabilities. And this is Medicare is in a health insurance in the US. So the authors looked at a chart of patients who had suffered an acute myocardial infarction between 1994 and 1995. And they observed that the prevalence of diabetes, hypertension, prior MI, and renal failure was significantly higher among Black men and women compared to non-Hispanic white men and women. But they also, after adjusting for several factors, they also saw and they concluded that despite their clinical profile, Black men and women were undergoing reperfusion therapy at a significantly lower rate than non-Hispanic white men and women, even when they needed it. And after adjusting for many factors, race still was the main factor that determined that difference. So it is obvious that there is a racial difference in the results. Do we know why this difference? It is unclear why this difference. Do we know if this is a disparity? It looks like this is a disparity. The researchers pointed out that there were other factors that needed to be considered to understand what happened here. For example, the preferences of the patient. Did the patient decline the procedure? The expertise and the preferences of the physician. Some factors about the hospital, the expertise, the volume of patients that they provided care for this particular procedure. So when they kept looking at the data, they pointed out that before doing the analysis, they excluded data from patients who had declined the procedure. So they only included patients who had accepted the procedure. Patients, in that sense, that those patient factors were eliminated from the equation from the beginning. The authors also claimed that they adjusted for hospital characteristics, therefore eliminating potential differences among hospitals. So that's why they thought that there were some physician factors mediating these differences. But from the database, we cannot really conclude that. It is possible, but we can't. Nonetheless, there is a disparity here. And again, this was one of the first publications that really brought to light this issue. This is another example about breast cancer. In this analysis, the investigators evaluated data of women who underwent surgery for breast cancer from 2005 to 2009, and they used a nationwide database, which included about 1,000 hospitals across 44 states in the United States. The authors mentioned some specific socioeconomic factors or characteristics that I would like to highlight before I show the analysis. The authors mentioned in the text that 17% of non-Hispanic white women and 10% of Asian women lived in poor neighborhoods, compared to 45% of African American women 35% of Hispanic women, and 34% of American Indian women or Native American women. So there were some indicators of differences in socioeconomic status in this sample. They also pointed out that the percent of women without insurance was pretty low, was in the single digits, yet the lowest, 1%, was among non-Hispanic white women. Now, in terms of the presentation, the clinical presentation of the disease, the authors described that African American women had 17% and Hispanic women had 20% increased odds of presenting with metastatic disease. And the presence of comorbidities was also significantly higher among African American women and Hispanic women. When adjusting for income and other factors, the authors reported that among African American women and Hispanic women, they had between 23 to 29% lower odds of undergoing mastectomy. And also, after adjusting for multiple factors, they saw that African American women and Hispanic women had an increased risk or odds of complications. However, they were only statistically significant for African American women. In terms of in-hospital mortality, although it seems like there is an increased risk among African American women, Hispanic women, and Asian women, it did not really reach statistical significance compared to non-Hispanic white women. So are these differences or disparities? With this information as is, we are not sure. There are some clear differences, like in other reports that I have already shown about breast cancer. So there are differences in clinical presentation. It is remarkable that African American women and Hispanic women have higher odds of metastatic disease at presentation. So that's more advanced disease. But there's also some differences in the performance of mastectomy and in post-surgical complications. After looking at age and comorbidities, African American women still had a significantly greater odds of complications. So again, it comes back to the questions about, in this case, were there any biological differences? What type of tumors? The presence of estrogen receptors or not? But also healthcare factors. Were these women undergoing screening as recommended? Were they informed of the results? Did they know what to do? Did they postpone and going back to the doctor for further evaluation or treatment? Were there other factors in the healthcare system? Maybe differences in health insurance or the protocols associated to health insurance coverage that possibly delayed some of the procedures or the screening. So these factors could have explained some of the differences that we observed. So although the analysis was initially focused on clinical presentation and complications, it seems like there are some disparities here that are not completely clear, but that need to be considered. There are some clear differences in clinical presentation, in the performance of mastectomy, and in post-surgical complications in this sample. After looking at age and comorbidities, African American women still had some greater and significant odds for complications. The differences in presentation could have been related to the tumor type, the age at diagnosis, family history. They could also have been related to some healthcare factors. The authors talk about health insurance. What about protocols related to the health insurance coverage that could have delayed the screening or access to surgery or to treatment? Other aspects that were not really available in the data set may be related to the healthcare resources, the quality of care, maybe workforce factors that were mentioned before in other examples, and the decision making, the physician's decision making, but also the patient's decision making. Did they choose to not go for the surgery very quickly? They think about it. What were the factors, cultural, individual factors that could have mediated a quick decision versus a delayed decision about having surgery or proceed with other treatments? But also the impact of socioeconomic factors, the stressors, financial responsibilities, financial toxicity, all of them may have influenced the findings, the outcomes that the authors published. In this example, in this study, the investigators performed a multi-level analysis of access and utilization of antenatal care in sub-Saharan Africa. And this was done within the context of a persistently elevated maternal mortality across the continent. The authors examined pooled surveys administered from 2006 to 2018 across 36 sub-Saharan countries, and evaluated data from women who had at least one child within 5 years of the preceding country survey. The authors categorized or put together or created some domains based on the questions that were asked in the survey. And the main reason I am showing this example is that the authors asked, or the surveys asked some questions about patient decision-making and patients' perspectives that influence access and or utilization of healthcare services. For instance, besides secondary and higher education, patient's autonomy, the ability of the patient alone making a decision, or when the patient made the decision with the husband compared to when the husband made the decision himself, those were associated with increased odds of utilization of healthcare services. Interestingly, they also evaluated media exposure and whether the pregnancy was wanted or if the women were using contraceptives. All of these indicators of higher utilization of healthcare services may be motivators and empowerment. Therefore, although socioeconomic status and education are consistently associated with higher utilization of healthcare services, patients' sense of self-efficacy and or advocacy could be a vehicle to empower them to participate in their own healthcare and contribute to the reduction of health disparities. Now, this is another perspective which is seldom discussed. In previous examples, I mentioned physician bias, explicit bias, implicit bias in some of the diagrams racism or discrimination were highlighted. In this situation is from the patient's perspective, and patients also have biases. Study participants have biases, and they could influence or interfere with the outcomes that we are pursuing. In this particular example, in this publication, I'm sorry, the investigators illustrate the experience of the healthcare workforce in 4 hospital settings in San Francisco, California. And the reported behaviors, patient behaviors, range from outright rejection to care to inappropriate compliments, filtracious remarks, and ethnic-based stereotypical jokes. They also reported barriers to addressing demeaning behavior, which included the clinical priorities. That means that they didn't have time to deal with the situation, lack of skills, lack of support, lack of knowledge of institutional policies, fear of being perceived as unprofessional, and perceived ineffectiveness of responding. Communication among human beings is complex. There are cognitive and linguistic aspects, cultural idioms or expressions, and bias, which will influence the very purpose of the communication and the outcomes. For instance, some of these dynamics could be mediating patients' decision-making, declining a procedure or taking a medication, or perceptions about health and healthcare. Therefore, we need to consider this not only when we are analyzing data, but also when we are interacting with our patients. Now, let's take a look at an example of the potential effects of healthcare policy on health outcomes and disparities. In this particular paper, the authors examined the changes in spending and care of patients from disadvantaged populations who underwent joint replacement after the implementation of a new policy by Medicare. Basically, what this is, Medicare created a policy to save costs, but also kind of track readmissions after surgery and quality of care. And it included incentives, but also included penalties, and whether the hospitals met the goals or not. With this background, with this backdrop of the policy, the investigators wanted to look at the impact of this policy and compare it among hospitals who took care of patients who are dual eligible. And that means there are some patients who can receive coverage by both Medicare, which I explained before, and Medicaid, which is a separate fund that in some states is used to also cover medical care. So in this analysis, they are comparing hospitals that take care of a high volume of patients that are dual eligible, Medicare, Medicaid, and hospitals with a low concentration or that serve patients that have a lower number of people who are not dual eligible. And this is an indicator of socioeconomic status. And it is also an indicator with lower socioeconomic status and a greater need for public assistance in health insurance. Very often, patients are going to have a more complex healthcare because they have more comorbidities or maybe delayed care that will influence the outcomes of surgery. So with that in mind, the authors compared before and after. They compared data before the implementation of the policy and data 1 year after the policy was implemented. And they found the following. This is the light blue is the high dual hospitals, and the dark blue is the low dual hospitals. They found before the implementation of the policy that hospitals that serve a high number of dual eligible patients were receiving a lower amount of bonus from Medicare than than hospitals that are serving a population with lower numbers of dual eligible patients. After the implementation of the policy, that, as it says here, the policy is tracking a number of readmissions, also bonuses and incentives, but also penalties. They found that hospitals that serve this high dual population were also paying higher penalties, and because possibly they were having a higher number of readmissions, and they were receiving a lower bonus compared to the low dual hospitals. In essence, a policy was created to reduce costs and possibly create a more efficient or shorter time care, but the consequences seem to be happening into the other direction. And this could have an impact, not only in the hospitals paying penalties, but also on the patients. Because if they are spending a shorter time in the hospital when they need to be a few more days in the hospital, if they are discharged before time, the likelihood of coming back to the hospital is very high. But also, what happens to the general outcomes? They are going to be possibly much more worse. So again, this is an example of a good intention, but it's going to impact the population that is at the highest risk the most. This example is actually more of a positive outlook. In this example is an analysis over time on the incidence of diabetes-related end-stage renal disease in the US. And the authors used data from a US registry and data set on a kidney disease. And the authors reported that over a 16-year period, American Indians experienced a 53% decrease in incidence of end-stage renal disease related to diabetes. Hispanics experienced a 33% decrease, and Blacks experienced a 20% decrease. Asians did not experience, there was no change, and for whites, there was a 10% increase. Nonetheless, by 2016, the end year of the analysis, although 3 of the populations had experienced significant decrease in incidence, still their incidence was 2 to 2.5 times higher than for non-Hispanic whites. So a reason for celebration, but a reason still to promote treatment and prevention and explore how else we can improve these outcomes. The investigators further explained that this decrease in incidence may be related to an increased number of prescriptions of ACE inhibitors over that time frame. So it could be the impact of medical guidelines in the treatment of hypertension or the treatment of diabetic nephropathy over that period of time. They also allude to a program among American Indians. It is a team-based diabetes program that has been successful, not only at increasing the number of prescriptions of ACE inhibitors, but also controlling blood pressure. So in essence, there is a success reported in this analysis, and also still a motive to continue working on this. In this slide, I am showing the titles of multiple publications on different public policies that are not necessarily focused or derived or come from within the healthcare system or healthcare policies, but are going to have some impact on them. And one of these policies is cash transfers that have been implemented across several countries. And they have demonstrated some gains and some positives, and some have not demonstrated the same amount of success in terms of impact on health. In terms of access to healthcare, they may go in the positive direction, but there are still some studies analyzing the data. Nonetheless, these are important to account and to take into consideration when we are looking at changes in prevalence of chronic diseases or any conditions in the population.